My name is Piper Colson. I'm with the New York State Department of Health and the Office of Drug User Health. I'm very honored to be moderating this presentation. And so I'm just going to do a quick introductions, and then turn over with some of the questions. So it's my honor to introduce Mila. Mila, I'm probably not going to pronounce your name correctly, and I'm sorry, but I'm going to really give it a go. Pavka, will you unmute and just say it for me, please? Save me the embarrassment.
No problem. My name is Mila Pahomova. I am the program manager at Matters. It's very nice to meet everyone.
Thank you. I appreciate it. I was listening to it on Google and everything, but I always panic. So thank you. So Mila, like she said, is the program manager at Matters and has over 15 years of experience in healthcare administration and management. She both completed an associate's degree in allied health sciences, as well as a bachelor's degree in nursing, and has a lifelong passion surrounding healthcare and the community, including volunteering and community outreach during times of need. Prior to joining Matters, she worked in both the private and public sector of healthcare, most recently working at Roswell Comprehensive Cancer Center as the ambulatory center administrator. Throughout the years, she's discovered a love for creating order out of chaos, as well as enhancing the functionality of programs and departments. Her greatest accomplishment as a manager has been building teams that feel empowered, supported, engaged, and focused on the organization's mission. She's excited to be a part of the program that shares in her love of providing help to those in need. And Stacy Rubin is a harm reduction consultant. She's a lifelong harm reductionist. She has worked on the streets and in community-based settings, designed and implemented unique holistic programs, and developed and facilitated training and education throughout the US. She is a second career nurse with a practice spanning HIV, home hospice, and drug user health. Most recently, she worked on the buprenorphine nurse care as a nurse care manager initiative funded by the New York City Department of Health, with the goal of expanding access to treatment by providing support for both patients and medical providers. She is committed to promoting equity, dignity, and whole person healing. So, like I said, I'm just really grateful to be in this space, and I'm just going to jump into the question. And Stacy, if you'd like to go first, the first question that we have is, how do you address resource issues such as the lack of internet access, phone or computer access to reach the most vulnerable populations in accessing buprenorphine care and treatment?
Hi. Hi, everybody. Thanks for being here. I didn't realize that we were going to just have questions before we spoke a little bit about the various models. So I think
actually, Stacy, if you want to start with the models,
yeah.
Piper's got some great questions, and I think with the added time of starting early, we can weave some of those in as well.
Great.
Awesome.
Yeah, I was assuming Q&A would be afterwards once we could speak about what the models were.
Sure, Stacy. Thanks.
Mila, are you okay with my going first and sharing my model? Great. Okay. So I'm going to be talking specifically about the buprenorphine nurse care manager model. And that comes out of Boston Medical Center, which is the office-based addiction treatment model. And that is, at the end of I have a couple slides which are links to the various organizations that I'm going to speak about for folks to get a little bit more information. And if this seems like a good fit for your area, then you can get more info on how to replicate these models. So Boston Medical Center had a wonderful, innovative approach to doing buprenorphine, which we know, I'm assuming most folks know about the landscape of buprenorphine here, right? So about 20 plus years ago, it became legal to prescribe, but very uniquely, different than methadone. One of the caveats for buprenorphine is that could be prescribed in an office-based setting. We know that folks that were moneyed and resourced had access to that for the past 20 years, but it's not until recently that folks that are on public insurance, that folks that are accessing safety net clinics are able to access buprenorphine, not from an opioid treatment program, but from their regular doctor, the same way that they would access their diabetes medication, their, medications for other health issues, right? So part of it is normalizing buprenorphine treatment and medication-assisted treatment for substances, both alcohol and opiates. Those are the tools we have. And so Boston Medical Center was doing this for quite a while, and it was a nurse-centered program. And what I mean by that is nurses are uniquely set up to do more holistic care than doctors or specialty or addiction specialists and so forth, or mental health providers, because the whole model of nursing is it's a biopsychosocial model, and it's a head-to-toe assessment. And that includes everything from, where are your aches and pains? How's your tummy doing? How are you standing in the office? What does your skin look like? What is your energy level? All of that is very basic part of any given nursing assessment. So what the Boston Medical Center did is that they made the nurse act as a sort of a spoken wheel model. We're at the center. So the nurse would work in terms of community outreach, patient education, one-on-one support for the patients, and also support for the providers and community organizations, and kind of act as the sort of central candidate to kind of spread the love in both directions. A lot of prescribers or physicians and nurse practitioners and PAs, while they might have been licensed or waivered, this is all pre-pandemic, waivered to prescribe buprenorphine, only a fraction of folks that had their waiver were actually prescribing buprenorphine. And part of that, again, was challenges around, providing adequate patient education, feeling like the population, drug use stigma, feeling like the population was going to be overwhelming for them. They didn't have the resources in their regular primary care office to help support folks to thrive on treatment. So the nurse would act as the sort of point person to expand other resources for the patient, but also really to support the provider to feel like they didn't have to do everything and would be the main point person for the patient. Again, nestled into the primary care setting, it afforded the patients a stronger link with a primary care provider and an ability to get their more holistic health needs met. A lot of the same folks that we were targeting with the buprenorphine initiative were folks that were often not in care on a regular basis with the same provider. They would access emergency rooms very often, or urgent care centers, would often wait till very late in a health issue to seek help. And again, all of this because of drug user stigma and how they were treated in the medical settings. So the nurse was again able to act as a liaison for, oh, my legs are all of a sudden, bloated and I can't walk as well, or, oh, my teeth are all of a sudden falling out and I'm having huge abscesses. How can I find a dentist? Or my blood sugar is like way out of control and I haven't actually tested it in 6 months, but I feel woozy every, couple of days. So all these kind of issues can be addressed by the buprenorphine nurse care manager. So what New York City did about, I want to say it's about 7 years ago, they took this model from Boston Medical Center and applied it to areas in the city that were very highly impacted by the overdose epidemic. So these were safety net clinics, many of them out in the boroughs, as well as in some of the very high overdose neighborhoods in Manhattan. If folks are familiar, I'm sure you're familiar that there's 5 boroughs in New York City, some of which have a little bit more of a I don't know, some which are less cosmopolitan and some of which are more interface and interfacing with the city as a whole, but some of which are quite isolated, like Staten Island or different parts of the Bronx are pretty out there and kind of in their own little hub. So they funded at first, I think it was 7 programs, and then it expanded to 15 programs. And these are all in different parts of the city. And the clinics vary from large hospital-based settings, which is where I was working. I should qualify, till about 6 months ago, I was the buprenorphine nurse care manager at Mount Sinai Health System, which was in East Harlem. And again, one of the highest hit neighborhoods in the city for accidental overdoses. So some of the programs were large hospital-based systems where there was a lot of interface with inpatient and emergency room and some of the specialty clinics like the Cancer Center and the Maternal and Child Health Center. And then other clinics that were funded were really standalone FQHCs out in, as I was saying, more isolated neighborhoods that really served their community, didn't have all the bells and whistles of a emergency room and inpatient beds, but had their own sort of, clinic culture and community culture. So one of the very interesting things about the initiative is that while they all have the nurse as the central person, they look quite different in different settings. So, and we can save some of that for the Q&A. I'm currently doing some consulting for the City Department of Health and helping them write curricula for the programs as a whole. So I do have more than when I was a nurse care manager. I have a better idea of what all the programs look like in the city and how they are both similar and very unique from each other. So, what else do I want to say in this first part? The programs evolve. So the main sort of pillars was that the ask of the Department of Health is that the lens be a harm reduction lens of providing care. There's no ask for abstinence at the onset. This plays out differently in different clinics in terms of, I would say, their own level of expansiveness around harm reduction and how integrated it is into their medical practice as a whole. The clinic that I worked at was a clinic specifically that had always targeted hepatitis C. Therefore, it had a very high, patient population of drug users, injection drug users, and drug users as a whole, because it had previously been a hepatitis C clinic that then expanded out to really doing drug user health in a more comprehensive way. Some of the more community-based clinics might be drawing from just the neighborhood and not have as much experience and expertise in working with active drug users. So while the lens from Department of Health, the ask is to really do this in as low threshold and as harm reduction based a way as possible, each clinic does have its own personality and their own growth around that, and hopefully continues to expand and lean into what low threshold and harm reduction based medical services really means. And as the programs have evolved, the pandemic really pushed things, accelerated things in a really unique way. Telehealth had never been part of buprenorphine prescribing, but then at these nurse care manager programs, but then with COVID, it actually became very much integrated into the program. Things that were taken for granted, like, every time you get a refill, you will do a drug urine. Well, all that had to change with COVID. And then a lot of people were reevaluating, well, why were we even asking for that? So there's a lot of stuff still to learn and expand. And I feel like there was a lot of wonderful things that happened, including the getting rid of the waiver necessity to be a prescriber. For myself, I was always just shocked that you could prescribe endless amounts of oxycodone, but you had to have special credentialing to prescribe buprenorphine, which is just so ridiculous. But, hopefully these are things, as the keynote speaker was saying, things that we are expanding into and kind of moving more and more in the direction of providing care for folks without all the stigma around it and without all the bureaucracy, and just really looking at where people are at and how can we help. which is not as prevalent in healthcare as we would like. Unfortunately, it's not always a grassroots up model. It's often a dictated down model. And then where do we actually meet the people and serve them best? So maybe I'll stop there, and then we can, save more for Q&A after and give Mila a chance to blab a bit.
Thanks, Stacy. Mila, I'll turn it over to you. I do see there's a question in the chat, but I want to acknowledge that that's there, and we'll get to that here in a little while.
Thank you. So as Piper mentioned, my name is Mila Pahomova. I'm the program manager for Matters, and I'm just going to be going over kind of the components of our program, what we do, and touch on all of those components throughout the presentation. I'll be sharing some slides here. Any questions you have, by all means, at the end, just let me know. And if I can't answer them, I will try to get an answer for you as best I can. Just want to make sure that you guys can see that.
Yep,
Yep, that's good.
looks good.
Okay. So these are all the components of our program and what we do. We will kind of dive into them as we go along in the presentation, but the biggest part of our program and what we do here is the electronic referral platform that is used to connect patients with opioid use disorder with medication-assisted treatment programs. We try to do this, make this connection as quickly as possible to make sure that needs are addressed quickly. So we tried to focus on any potential barriers that patients may face, and came across that the cost of medication was a major barrier, and transportation to and from their first appointment. So we created those vouchers to help make those connections for the individuals, which we'll kind of go over further. Originally, our program started with 2 emergency medicine physicians who saw a vast population of patients with presenting with post-overdose and acute withdrawal symptoms, and no clear way to connect them to the resources that the patients needed. So they created this platform. And now we not only get referrals from emergency departments, but we partner with correctional facilities, EMS agencies. We get referrals from inpatient units, law enforcement, and telemedicine as well. Basically, any individual, any organization that has an individual in front of them with opioid use disorder can partner with us and make those referrals. Now, we have 3 primary goals with the initial patient encounter. And the first is being the evaluation of the patient. We want to make sure that the patient is a good candidate for our program, more so that the patient is a good candidate for outpatient programs, medication-assisted treatment versus inpatient, because we typically only partner with external treatment organizations. Now, this evaluation does not necessarily need to happen in person. Some patients may not be comfortable going into a healthcare facility or might be located in a rural area. So with that, because we try to keep matters as low barrier as possible, we do provide telemedicine services 24/7 for all of our patients. We partnered with the Western New York Opioid Addiction Treatment Hotline for those located within the Western New York region. It is 24/7. Then anyone outside of the Western New York region can access an emergency virtual appointment through either ECMC or Kaleida Health online. Those appointments are usually available within an hour or so, and can make those connections, get a referral set up, as well as provide or evaluate for an eligibility for a bridge prescription for buprenorphine. So the second, since we're talking buprenorphine, the access to medication. We specifically prioritize access to buprenorphine. So if the patient is in a medical environment, we want to ensure that the patient is prescribed buprenorphine, but also administered buprenorphine on site. That is our recommendation. It's not mandatory, but we recommend that. And then the third and final goal is to refer the patient to treatment. That is the bread and butters of what the Matters program is. And we want to solidify that connection between the patient and the treatment. So this is our current footprint in New York State. We originally started in the Western New York area, Buffalo specifically, and now are in all 10 regions within New York State. This map is actually interactive on our site on mattersnetwork.org. You can go in there and kind of focus in on more specific, regions and areas to see who our partners are. Just some context here, that Black icons are our referring sites or hospitals. The red icons are law enforcement. Blue icons are treatment centers, and then the yellow icons are our future or potential partners that we're working with. So our mission at Matters is to provide every person living with substance use and mental health disorders multiple pathways to treatment and resources within their own community by creating an extensive network focused on improving access and eliminating financial, geographical, and social barriers. Our vision is to be utilized across the United States as a way to reduce morbidity and mortality rates for people living with substance use and mental health disorders by linking them to stigma-free treatment and resources so that no matter what stage of readiness they are in, help is always available. And then our values, meaningful connections. We will always link individuals to services and resources no matter what steps they are ready to take. Advocacy. We will speak up, support, and defend those who need help. Trust. We will always be an honest and reliable source. Tenacity. We will always be determined to reach the unreachable and overcome obstacles. Education and empowerment. We will make prevention and treatment information readily available so that those who choose to take action can do so with knowledge and understanding. Reach and responsiveness, and stigma-free services and support. Now, the next few slides kind of go over the actual referral platform and how it works. We did recently develop an app that can be downloaded via Google Play and App Store. We try to keep the referral process very simple and quick at the individual's fingertips. This app can be utilized by anyone, whether you're an individual that needs help, a provider, community partner. It basically houses everything that we have on our site, but just on an app. Here you can see the other options. Once you choose the initial option, you can request telemedicine visits here, refer a patient if you're an individual who provides care, request any harm reduction resources. And then there's educational videos. Basically anything you'll find on our site is all housed here. The other way that we make the referral process happen is by visiting our website at mattersnetwork.org. And then there's a tab at the top that says submit a referral. This then takes you to our actual platform, which is housed on the Health Commerce site with the Department of Health. There's an authentication code that we provide all of our partners. Right now, the reason for that is so that patients don't refer themselves over and over again. So the partners all get the same authentication code. You would enter that there, and then that takes you to our buprenorphine protocol. Once a patient is assessed and is found to be in moderate to severe withdrawal, we do recommend that the patient be given 8 milligrams of buprenorphine on site, as well as be prescribed 8 milligrams twice a day sublingual for 14 days. This allows for some clinical flexibility, as well as decreases likelihood of medication lapse, just in case a clinic isn't available to take a patient right away. This way we know that they're taken care of. Now, the next is just some demographic information. The whole process that we've made here is to be utilized not only by the provider, but the patient as well. We really want our patients to kind of own this and make these decisions. So here it will be just demographic information. There are 3 consents in our form, and the voicemail consent is the only one that is optional. The other 2 consents have to be acknowledged in order for the referral to be submitted. Now here, when the patient chooses what kind of insurance they have, if they have no insurance or Medicaid, that automatically triggers a medication voucher for any kind of oral buprenorphine up to 14 days. The reason that we included Medicaid in this, out of all the insurances, is we found that most of our patients with Medicaid tend to not realize that they are in an inactive status. So because we don't want them to have medication lapse, we want to make sure that we give them what they need until they get to their treatment center. The rest is just some medical history. This information is really useful for the clinic that they choose, just so they have some background on the patient. Then here the referrer would choose which location they're referring from. And then the individual can also choose whether they would like to participate in a peer support service. This is separate than our clinical service. The patient can choose, if they choose to opt in, they choose yes, it drops down a region, county, whichever services are available there. And then the peer service automatically gets their contact information only, no other medical information. At the bottom, there's another consent. And then this is pretty much the only part that the referrer has to do, is choose the setting that they are referring from. And depending on the setting, it will then drop down a certain amount of questions that is pertaining to the actual setting they're in. For instance, here in emergency department, it's what was the purpose for the visit? Was buprenorphine given? Did they get any harm reduction resources? Then this gets submitted and we are taken to the appointment page. So this gets automatically populated by the demographics entry from the patient. It's always within a 10-mile radius. Here we have Buffalo because that's just where I am. And so there's the option of choosing an in-person clinic, but there's also, if you notice on the top left, a telemedicine list, which means that if a patient is not interested in going in person, it will show the entire telemedicine list for the entire state that a patient can partake in. So once they click on one of the red icons, it'll show what clinic it is, where the location is, and then which treatments are available. All of our clinics that we partner with have to have buprenorphine treatment. Otherwise, we can't partner with them. But then they do add anything else that they have available, so that this way the individual can make a really personalized choice and decision as to where they go and for what kind of treatment. Now, once they choose a date, this is kind of like the registration page. The individual only chooses a date, not a time. The clinic will communicate with the patient and then provide a time available to make that first appointment. We do also provide transportation to all of our patients. Anyone getting referred through the site, we provide round trip transportation to and from their first appointment. And then you just would click register and that would submit the referral. That would then take you to the confirmation page. And just a few key things to mention here. The entire process is about 3 to 5 minutes long. Obviously, the presentation took a little longer, but the form itself is about 3 minutes long. There are no phone calls or anything that has to happen from the referrer, which is really convenient, especially for those in the emergency departments. All of these blue arrows at the bottom happen automatically. First, the confirmation gets faxed over to the referring site. So discharge instructions, the medication voucher for 14 days of buprenorphine, transportation if they opted in, and so forth. At the same time, the information is sent over to the clinic automatically. The clinic will then contact the patient within 24 to 48 hours. The voucher for the medication and transportation gets printed out. If they chose to have transportation, they can either reach out to us, they'll get a printout with a phone number, or one of our regional care coordinators will reach out to the patients directly and schedule that round trip. Then the information gets sent to the peers if they opted in for it, only contact information, name and phone number pretty much. They also respond within 24 to 48 hours. And then an email confirmation and a text confirmation goes to the patient. For our medication voucher, just to reiterate, it is for up to 14 days for oral buprenorphine. We partner with major chains such as Walgreens, Wegmans, CVS, and Wayne Reed within New York City, as well as a vast amount of independent pharmacies. Our transportation is housed through Uber Health. Again, we cover only the first round trip to and from the clinic. After that, it's pretty much on the clinic to help facilitate the transportation for the subsequent appointments. Now, aside from that, we do provide harm reduction resources. We provide fentanyl test strips, xylazine test strips, and Narcan. These are absolutely free to anyone. They can be ordered through our app or on our site. For organizations, we provide 1,200 of fentanyl per order and 600 of xylazine per order. And for individuals, it is 10 of each. There could be multiple orders. It's just per order. This is how much we provide. And then we are also distributing 15 harm reduction vending machines throughout New York State, which will provide all of our harm reduction resources in there. In the next couple of months or so, we'll be populating our site with a map of where those locations are. And the last few slides are kind of some data. This is as of April 30th. So an updated amount is, as of a couple of weeks ago, we're at about 840,000 fentanyl test strips distributed to organizations and about 15,000 fentanyl test strips distributed to individuals. Xylazine, we just started in June and have distributed almost 200,000 in 1 month. And just our year in review, we've made over 1,500 partners in 2022. Just in 2022 alone, we distributed 55,000 fentanyl test strips. So you can see kind of how we've expanded within that year. And we are statewide. And then just some key numbers, 24% of our patients opted in for transportation assistance. There was a 4 times increase in medication vouchers redeemed. 85% of our patients were issued a 14-day medication voucher, and 77% of patients received a bridge script for buprenorphine. The last slide that I'll go over here just kind of talks about our telemedicine. 59% of our referrals come through telemedicine, and we are seeing the same exact trend happen for this year. So that is kind of our program and what we do. And I'll open it up for questions at this point.
Mila, real quick before we go to the questions, Stacy, I know that you had some slides prepared. Did you want to share those?
Yeah, there was one slide which I wanted to share, which was contact information for the New York City Department of Health Nurse Care Manager Program. And there it is. And the Boston Medical Center. And then an outgrowth of the Boston Medical Center is something called the Graykin Institute for Addiction Training and Technical Assistance. And they have training specific for the nurse care manager model. So those were resources if folks were interested in learning more and ways that they could perhaps replicate the model or get more information. So that's the slide. Mila, I tried downloading the app and I couldn't find it. Can you tell us how best to find the app? Because it sounds amazing.
Sure, it is. I know it's Matters Network specifically in the App Store.
Yeah, Matters now. Okay, let's see. We're going to do a in-person tutorial right now. Matters, nothing came up. Let's see.
And just so everyone knows, I dropped the mattersnetwork.org the website address in the chat.
So for folks to know, you have to put in Matters Network, and here it is downloading as we speak. I'm very excited about this. This sounds unbelievable and amazing.
Thank you. Yeah, we're very excited about it. We've gotten some great feedback about it, just the access. It's easy to access for everyone. So
and I to go into questions, there's somebody asked twice, how are you funded?
Matters?
Yes.
We are funded with Department of Health and OASIS at the moment.
Great. And then I have another question. It is, Tanya, I'm reading your question. Will that be take home, or what about those who don't have an address? How will we support them? What about a locker street system for pickup?
So I guess if it's in terms of harm reduction resources, that's fully anonymous. The patient puts in wherever they want it dropped off to. It could be a friend's address or a clinic's address, anything pretty much. They don't have to have their own address. Pretty much anything that is closest to where they are, we can deliver it there as long as it's someone that's trustworthy for the patient.
Okay, great. And then another question, do incarcerated patients do telemed and get their meds started while incarcerated?
It really depends on the facility. Some facilities do administer when they're there and some do not, but we actually do have a vast population coming from correctional facilities, and they do get telemedicine as well as get more often they get connected with a treatment once they are discharged.
Great, thank you. There is a question, Stacy, it was for you. This may you may want to do this privately, but there was a question, someone interested in who's prescribing all of the Oxy.
That was a joke. I think the question is a joke as well. Yeah. One thing I forgot to say, I'm glad they brought up something though about prescribing. One of the main goals of the initiative was to expand the number of providers that were prescribing. So in order to get the grant, and for the programs that I worked in, it's funded through the New York City Department of Health, but I'm sure there are nurse care managers programs funded throughout the country through either city or state departments of health, as well as probably private, other privates. But to apply for the grant, there has to be a buprenorphine champion, which would be a MD typically. But the goal of the grant was also to, in whatever setting it was, to expand the number of prescribers. So again, the spoken wheel model, the nurse and the champion as the center, but the goal was to bring on through, let's say, the year of your grant, at least another 4 prescribers, because a big piece of the grant was not only to have each patient have their kind of person, their case manager person to help with all the logistics of, on-time scripts and changing insurance and pharmacies and all of that, but also so that the prescribers would feel supported and feel more comfortable prescribing buprenorphine. And then hopefully they will feel comfortable to expand their practice of prescribing in general, even without the nurse care manager. So that's who's prescribing, but typically not the Oxy.
Thanks, Stacy. Another question that came in, is it required by New York State law that one formulation of all forms of MAT is provided to persons in all the state prisons and county jails who are diagnosed with OUD or AUD?
I honestly am not sure. I can find out and get back to you about that, but I don't really know. I would think not, just because each correctional facility that we've worked with, it has different rules. So
I apologize. Kelly Ramsey just said that it wasn't a question. It was just a law. It was a statement. Thank
Gotcha.
you, Kelly. Yeah, sorry about that. And then there's a question. Do you use the nurse care model for billing purposes?
So good question. And the answer is no, because unfortunately, and this is a state by state thing, very interesting. The model was created in Massachusetts where nurses can bill for visits. And in New York, nurses cannot bill for visits. And so part of why it was very successful in Massachusetts, it's because it doesn't have to be externally funded. It could be funded through billing in the health system. But New York had to come up with the monies. And the goal originally was that organizations would then, once they saw that the program was successful, they would then fund it from within the health institution. That has not happened as of yet, and the grant has continued to be offered. And unfortunately, I don't know what the changes in New York will be like in terms of nurses being able to bill. I did see something in the chat responding to me from Rachel. Maybe she wants to
Yeah, Rachel had a question. I'm making sure that there are question marks after the messages as opposed to periods, which mean they're statements. So, Stacy, have you heard of LT Bupe programs using incentives for buprenorphine uptake or maintenance? Do you have any thoughts on it?
I'm not sure what the LT means. Oh, low threshold, sorry. Um, I don't think folks need incentives to be on buprenorphine. And I think that that is a really bad direction to go in. I think, you know, when folks are looking at treatment, I think that has to be from inside. Medication is only one part of the treatment in my belief system. I know this is not what's coming down from the, you know, feds in terms of MAT in general, but I think, you know, medication is a wonderful tool, and a person has to want to make changes in their life, and it's part of a much bigger process. So if you are trading, okay, we'll give you medication for money, that just gets rid of any kind of self-agency the person has, and it gets rid of any real healing component in terms of making changes around choice. So personally, I would say that's just such a bad direction to go in, but that's as a, you know, person that has worked with folks struggling with addictions for decades. And, you know, I don't know, we did that with, you know, we paid people to get the COVID vaccine, but I don't know, it's not what I would have, not what I would do in terms of treatment, because this isn't like a one-shot deal like a COVID vaccine, and it's not about public health, it's about personal health. And do we want to pay people to care about themselves? I don't know.
Thanks, Stacy. So we are at our 1:15 mark, so I want to be conscious of that. And just there's a statement from Kelly Ramsey she's from Oasis. They are working on nurse billing issues in New York State with the DOH, OHIP, and Medicaid. So I just wanted to end on that statement because I kind of feel like that fit in. So I am going to thank you both so much for coming and sharing on your programs. Thank you everyone for your patience with me as I scrambled popping on. So